Hello everyone, my name is Jennifer Jackson. I'm a registered nurse and I'm currently a doctoral researcher at King's College London. I have an interest in supporting nurses and supporting people who work in healthcare to provide great patient care and still be taking care of themselves as well. So this presentation is about how to manage your exposure to adversity, and it's a conversation about burnout and resilience. This can apply to anyone working in healthcare. The research is done with nurses, but I think it does apply more broadly. And also there may be interest for people outside of healthcare as well. So this is not about buzzword resilience. This is about research, and this is some evidence-based ideas to share with you so that you can reflect on your own resilience. So my interest in resilience and resilience research began with my own experiences. Here I am as a bright-eyed nurse in intensive care. I had a red nose on for Halloween that year to try and brighten things up for the patients a little bit, but I had wanted to work in intensive care because I heard it was really challenging and really exciting and really kind of mentally stimulating. And when I got to intensive care, I realized that my understandings of it had been completely wrong. And it was actually emotionally challenging and emotionally draining. And I was not prepared for the sheer volume of human suffering that I would witness. The unit I worked in was partnered with a cancer center. And so our mortality rate for patients within 1 year was 50%. So I had many, many patients die, and also had many that I discharged but were not going to live, probably past another 6 months. And while death is not necessarily a horrible thing, if someone can experience comfort and be with family and that type of thing, it was just the trauma of the situations that I was seeing over and over again that was just absolutely horrible. I didn't have good coping strategies, and ultimately I got really burnt out because of this. So I wanted to do research to find out how we can support nurses and try and consolidate some information around burnout and resilience. So I often have challenges when I think about resilience. And with my own research, I have times where I think I should just pitch it all and say, forget it. Because if I'm asking people to be resilient, like if I'm asking the sailors on this ship to be resilient, well, that's completely impossible because their ship is so badly damaged that it couldn't possibly float. So with resilience, I'm not saying, and I would never say, that people should push through horrible working conditions and they have to rise above any and every circumstance. What I'm saying is that there's no such thing as an adversity-free workplace or an adversity-free environment. And so knowing that, how can we use resilience as a way to enable our own coping and our own thriving in those environments? But this does not mean that we leave the environment as is and don't try and fix things as well. So this is there are two sides to this coin, and so I'm talking about an individual level one of them, but I fully acknowledge, and I have lately my research is looking at a systems level approach as well. So first, we'll talk about burnout. When I started my research, I wanted to focus on resilience, but you ask people about love and they tell you about heartache. So I found I had to engage with burnout a little more than I initially wanted to. But I found that burnout has a long tradition in nursing. It was first described in the 1970s, and there is no really standard definition of burnout. There's as many definitions as there are authors. However, there's generally three key elements: a high emotional exhaustion, high depersonalization, cynicism, or detachment. So not seeing patients as people anymore, seeing them as cases or tasks or bed blockers and that type of thing. And also low levels of personal effectiveness or accomplishment. So just not caring anymore, not achieving anything, or like doing the bare minimum, providing care that is safe, but does not go above and beyond in terms of trying to help the patient reach their goals or working with family or anything along those lines. So these images are taken from the first article that was published about burnout, and they depict kind of this nice white lady in a starchy uniform going down a deep shaft and then coming up this windy staircase. And as much as these images, I think they really highlighted how we understood burnout at the time, they continue to be really relevant today because our understanding of burnout resilience have really moved on. But I think the mentality that we're stuck with is what is shown here. So that, you're all by yourself, you have to fix yourself and climb back up the stairs on your own, and that there's a lot of individual responsibility. And I really don't see burnout that way at all. So we'll discuss that a little further later on. On the flip side, what is resilience? So resilience is evidence-based and has over 40 years of research. Started in psychology, but is now studied in education, in the military, in healthcare, in lots of different disciplines. And the understanding of resilience has evolved over time. Initially, it was thought of as something that you were. So you are resilient, you are not resilient. And now we understand it to be a process or something that you do. So it is something that you can work on and go through and then become able to cope with whatever it is you're facing. So the state and trait language has kind of hung around a lot, and I find even myself, I slip into saying I feel resilient or I am resilient. But what we're really looking at these days is a process. So something that people can do and modify and change. And so that's why it's been an important thing to focus on, is because when we look at a behavior, behaviors can be impacted by interventions. It's very hard to change someone's personality through external interventions. I think we all know somebody whose personality we would like to change through external interventions, but that's a very hard thing to do. However, to change a behavior or a process is much easier. So when we think about resilience as a process, it opens the door for us to do something about it. So I encourage you to consider it as a process to see how can behavior be modified by things in the environment or practices that we put into place. So this image, and I've got references at the end, this image depicts different understandings of resilience. So it's not ideal in that the words are over the lines and things, but I'm hoping that with an explanation we can see this as a starting point. So all resilience processes begin with a challenge. Some people say this has to be an adversity experience. Some people say it has to be trauma, because if it's not trauma level, then it's just a regular everyday stressor, and one should be able to deal with that without needing a resilience process. Other people say that this doesn't have to be at the trauma level. Some say that it doesn't even necessarily have to be something negative. It could be something like a wedding or a graduation that are ostensibly positive things, but bring with them a lot of expectations and things that can be really difficult. So I personally see resilience as any type of adversity, the resilience process is starting with any type of adversity, but there's different conversations among researchers about what's the right approach. The gray box is where my research fits, so we'll come back to that a little bit later. But if we think about the midline there as being baseline functioning, and I know that that's what is one person's baseline functioning, that's completely subjective. And so I acknowledge that. I'm just trying to give us kind of an understanding that we can use as sort of a thought experiment here. So this is how someone's baseline functioning is determined by themselves. It's not an objective judgment on how someone is doing or not doing, but just to look at like how you kind of regularly do day to day. So say a person experiences adversity, so they can have different processes after. So where we have the recovery line, the dip, and then they come back, that can be considered a resilience process because they have decrease in baseline functioning, but then return to baseline functioning after. This person may also have a decrease, but may not decrease as much as they might have in other circumstances, or they might not go down as much as we expect them to. So they may also go back to baseline functioning more quickly than we expect them to. Looking at resistance, this process is where we may expect a decrease in functioning, but they are able to maintain baseline functioning. And finally, the rebound trajectory here is there's a decrease in baseline functioning, but at the end, they have an increase in functioning, which is considered post-traumatic growth. So this shows that there are lots of different ways to have a process of resilience. And resilience does not mean that you never have a decrease in baseline functioning. It does not mean that everything's fine all the time. It means that when there is a drop, whatever that might look like, you are able to recover from that. And that is what is really important, is that recovery, and that you are able to come back to a level that you are happy with and consider to be a good level of functioning for yourself. So also, this shows that we can't compare resilience processes with other people very effectively, because depending on what challenge it is that we're facing, we could have a lot of different things happening. So just to say, resilience is not one size fits all, and there's lots of different ways that people can experience a resilience process. So just some myth busting here. So as I mentioned before, resilience does not mean you just accept bad working conditions. And it doesn't mean that you are always fine and nothing ever phases you. It means that you are allowed, we are all human, we are allowed to have decreases in functioning and be upset and maybe not do well for a period of time. But it means that we're able to recover from that. And it also means that we are in environments that support us to do that. We're not in horrible working conditions. So resilience is a process. It's not something you are, it's something you do. And it's a developmental process. So it's something that we get better at over time. So in conjunction with burnout, burnout is not a personal failure. Burnout with the nurses I spoke to is often because the environment did not enable them to enact coping strategies that they knew would be effective. So burnout is also an opportunity to learn and to enhance a resilience process. So if we see resilience as something we learn over the period of our lives, then when we do experience burnout, we can see that as an opportunity for learning and for growth, not as a failure. So one of my biggest frustrations with resilience in kind of a popular press discussion is people say, you know, everybody has their own strategies, it's different for everyone. And yes and no. So when we think about food as a parallel example, I love food. When we think about food, we have, you know, Italian cuisine, we have various kinds of Asian cuisine, we have Indian cuisine, we have American cuisine, we have all kinds of different foods. And they all look very different on a plate, they taste very different, but they generally have some kind of starch, some kind of protein, some kind of vegetables. And so what I have tried to do here is unpick what are the starch, the protein, and the vegetables that you need in a resilience process. And it can look different in lots of different ways, but there are core elements that help the process happen. Also, resilience is beyond individuals. There are lots of studies looking, especially with Indigenous communities, that look at resilience at a community level, and the idea that one person individually doing well is not necessarily success if everyone else around them is struggling. So my work does focus on an individual level. There are limitations of that, and there are lots of critiques of that. And just to keep in mind that no man is an island, and we have to consider how resilience is being processed at a community and organizational level as well. So this image outlines the grounded theory I generated in my master's, and this was looking at the process of resilience for critical care nurses. And broken down, this is what the resilience process looks like. So basically, we identify adversity, We have to be able to pick out what adversity is affecting us. We have to be aware of the impact it is having on us. We apply techniques to manage that adversity and manage that impact, and then we can evaluate the process and outcomes. And when I say evaluate, I mean evaluate for ourselves, not objectively evaluate and, give a determination on someone else. It's to reflect on ourselves and say, have we grown over time? Are we where we want to be? What could we possibly do differently? So I'm going to talk about each of these in more detail. So I focus on workplace adversity here because that's where the focus was within my research. But I also recognize that you can't silo adversity. Adversity is adversity. And if it happens in your personal life, it can spill over to your work life and vice versa. So I needed to have a manageable research program. So that's where my focus has been. But I acknowledge that adversity can come from anywhere. So inspired by some work by Michael Trainer, I've been thinking about how we understand adversity. And I would say that it's valuable to break it into intrinsic and extrinsic things. So within healthcare, we are never going, and everywhere, we're never going to have adversity-free environments. And there can be adversity such as death and dying, or hearing stories of trauma, or working with patients who are very resistant to care. There can be all kinds of challenges, but there are some that are kind of part and parcel of being a nurse or being a healthcare professional. You're always going to face a degree of that. So that's one set of adversity that we can develop responses to. I would say the other set is extrinsic, or things that are, if you will, artificially created and do not necessarily need to be present. So these are things that we can directly control. So staffing shortages, workload, budgets, funding for healthcare, respect for professionals, engagement with families and community, all those kinds of things. And when that's going wrong, I think we need to separate that out, because then we can understand that as something we can do something about. So that is less about the issues within the profession and more about the system and the environment. And of course, there's other things that happen too. And I find that when we talk about adversity, sometimes there can be a tendency to go around in circles about how bad everything is. And while it is important to understand and identify what's going on, the focus needs to be on what can we do about this? What are things that we do not necessarily need to be facing right now? So as a sidebar, I want to just include a brief piece from my PhD research. So in thinking about things that are adverse, we want to consider all different aspects of work. And so as a tool for understanding, I've categorized nursing work in these 4 different domains. And again, I'm not saying this is exclusive. As soon as you start putting things in boxes, obviously there are criticisms of this, and people can say, well, this is missing or this should be added, etc. So this is just something to help move our thinking forward. This is not a comprehensive list, and that's never what I was trying to do. So just to say, there's physical labor, there can be emotional labor, which can occur when the classic example is you feel really stressed, but you are trying to project an aura of calm so that, the patient and family or whomever you're working with does not also get stressed. There's the cognitive labor in terms of maintaining situational awareness, thinking about all the different things that have to be done for each patient, constantly triaging and deciding what's the priority, how are we going to troubleshoot, and so forth. And then also the organizational labor. This is from work from Davina Allen, and looks at the coordinating and something that people often refer to as paperwork and are kind of dismissive of, but though that paperwork can create people's trajectories through the healthcare system. For example, if their discharge summary isn't well written, well, that can have ripple effects, from discharge forward for months. So all of these different things can maybe help us understand adversity in that it's not only structural things around us there can be adversity in each of these different domains. And it may be helpful for some people to try and consider, what does adversity look like in an emotional labor context or a cognitive labor context. And that might help drill down further in the hopes that you can design interventions that are really precisely targeted. So returning to resilience. So this list is from my master's, and these are things that nurses told me they found to be adverse. So the point is not that you read all of this. The point is to say there is a long list. And so what I think is most important is to look and say, what is adverse for you? And what do you find to be the biggest problems? And what are the things you can control? And what are the things you can't control? And then we need to work together to decrease adversity. So don't accept things that we can change. I'm a huge advocate of political action and encourage people to think about, if you don't have enough staff, can you write to an elected representative and say, look, the healthcare system is suboptimal. We're not having enough nurses, doctors, whomever. And I vote for candidates and I expect you to do something about it. You can vote, you can organize political campaigns, you can collect data at a ward level and demonstrate the impact that different policies are having. There's all kinds of things you can do. So I just really encourage a move away from powerlessness and to say, how can we take action and what things can we make better? So moving to the next phase, that is awareness. And so it is very important to be aware of the impact of adversity on you. So for accessibility, I'm going to read this quote out loud. I could see the triggers and then the 2020 hindsight that I was seeing a bit then, but looking back now, it's definitely clearer. And hopefully I would recognize it sooner and possibly be able to change the situation sooner. So this was a participant who told me about how she had gone into a very difficult burnout situation. And then once she had recovered from that, she was able to look back and say, there were triggers for me along the way. And now I can see that and I can respond to that. So you'll have to understand what burnout looks like for you. Some people eat more, some people eat less. Some people sleep more, some people can't sleep at all. There's different ways that it manifests, but it's important to think about when you're really stressed out or when things are not going well, what does that look like? And how can you catch that before it gets really difficult to the point where you'd have to take time off work or school or things of that nature? Without awareness, it's impossible for anyone to have a resilience process, because awareness is what drives the push towards resilience. If you're not aware of the impact it's having on you, you're going to be burnt out. So if you've ever asked someone about, breakup or something difficult, and they're like, oh, I'm fine. I'm completely fine. Well, that's a sign that they're lacking awareness, and it's a warning flag that burnout is about to follow. So managing exposure, I would say this is the most important part. This is what you actually do. So what do you do after you have experienced adversity and you're aware of the impact it's having on you? Nurses talked about these in different categories, and so I'm going to explain each of those for you now. So protecting is like building a shell. Nurses talking about a shell, a shield, a coat of armor. Protecting is where you have to just have a thick skin towards some of the adversity you face. For example, if you have a patient scream horrible things at you, the first time that happens, you're probably going to go cry in a back room and be really upset, rightfully so. But the 10th or 15th time you have a patient scream horrible things at you, you're probably going to be able to stop and say, look, this person is psychotic. They don't mean this. This is a stressful situation for them. They're out of their natural environment, and they're not upset with me personally. There is a bigger picture here. And I'm not trying to normalize verbal violence or say that that's okay, but when we work with people who are not always in their right mental state, or people who are under great pressure and duress and are extremely worried, it doesn't bring out the best in anyone. So at some level, you have to have a shell. So nurses talked about developing that shell over time and saying, look, we just have to kind of step away from this a bit. Some researchers think this is a bad idea and think that this leads to burnout or some really nasty outcomes. I see it a bit as being on a dimmer switch, because we don't want to completely have so much shell that we're so distanced from what's happening that we can't engage anymore. But there are times where you need to step back and perhaps use something like depersonalizing the patient. That is controversial, but I stand by that can be an effective tool if it's used appropriately. For example, when I have done CPR, I'm not thinking about the patient as a person. I'm not thinking about their family or the care I provide or being holistic. I'm thinking about doing compressions, and that is it. Because if I lose my focus, or if I start thinking about any of that stuff, or if I consider how much pain I am inflicting on someone, I can't do it. And in that moment, the most important thing is that compressions are done effectively so we can perfuse their brain. So in that moment, I think depersonalization can be a helpful thing. But the thing is, you have to be able to shut that off and engage with the patient as a person and their family and that type of thing after that period is done. When people shut it off completely all the time, they are in grave trouble. When we move to processing, I think this is the most important part. If I could give a single piece of advice, it would be to talk to people about what happens to you. Talk about the things that are difficult in your life. That can be talking to healthcare professionals such as a social worker or a psychologist or a psychiatrist. That can be formal debriefing. That can be a casual chat with your partner in the car. That can be, over coffee or drinks with colleagues. It can even occur in handover. You perhaps have heard handovers where you're getting information about a patient and somebody could say, okay, we took them to CT, they're on propofol dose increased, and they had a hard time settling when they came back. That's one version of report. Another could be, oh my gosh, I had such a stressful day, it was so difficult, and the patient was thrashing around and we had to up the propofol and we had to get them to CT. They wouldn't hold still. It took over an hour. It was super stressful. Finally got them back. They haven't settled well, and so forth. So you can see that both are conveying the necessary clinical information, but also one is where someone is taking time to unload the stress that they've experienced as well. So I think it is really, really important to talk about what happens to you and also listen to others talk about what happens to you. It doesn't have to be formal. It can be a private, quiet thing. And I just cannot stress how important that is. That doesn't mean you always have to be available. If you are not able to listen to someone else at that point, it's okay to step back, but I would make sure that you've connected them or try to refer them to someone who can. So if you've had a rough day and your partner wants to talk and you just can't, maybe you can suggest that they call a sibling or say, you know what, I need 15 minutes to collect myself and we'll have this conversation a little bit later. Whatever the case may be, but find people to talk to and listen to others. Moving to decontaminating, this is what most people in the popular press talk about when they are talking about resilience. So things like yoga, run 5K, eat well, sleep well, have healthy relationships with your partner and your friends, those types of things. So that's all really important. And I agree that that is an essential part of resilience processes and managing exposure. But I want us to make sure that we see that as one part of a whole system. You can't yoga away chronic short staffing, and you also can't kind of run 5K away from, grief and lots of other difficult things. So those are really important, taking care of your mind and your body and having those healthy relationships, but it's also a part of a whole and should be seen that way. Finally, for the critical care nurses, they talked about distancing, which is physically being away from the source of stress. For many of them, it was the bedside. And so they would do everything from kind of a micro distancing. One nurse told me that if she knew she was going to have a really stressful day, she'd drink more water because she said, they can't stop me from having to go to the bathroom. And so even just going to the bathroom for her, she would get 45 seconds to 2 minutes away. She could take some deep breaths, collect her thoughts, and then go back out. Other nurses said they would go gather up supplies and just be in the supply room. So they're still at work, but they were just physically moving away a little bit. Examples of this can include breaks. I am a huge advocate for breaks. And I think even if you can, with the buddy next to you, cover their patients for 5 minutes, they cover your patients for 5 minutes, except on the most insane days, you should be able to find 10 minutes that you can look after each other's patients so that somebody can get a drink and, have a comfort break, look after themselves. I definitely think people should have breaks. It's also important to have annual leave or vacations and get away from work. Don't go into the hospital or don't be as engaged in that community setting, whatever the case may be. Also, distancing can look like knowing when to leave. Nurses told me that they would plan years in advance to leave their clinical setting. Whenever they said, you know what, I'm enjoying intensive care now, but I know I can only keep up with it for another 3 years. So I've started taking courses, or I've, started doing more professional development so that when it's time for me to get another job, I'm going to be able to move on. So that comes with awareness and also knowing that distancing is a way to address these issues. Additionally, from further research, some other strategies came forward. So one is practical strategies. So set yourself up for success. So this means being organized, having uniforms ready for work, having meals ready to take in for your shifts, having a good sleep routine, having a routine when you come home from work, whatever the case may be, set yourself up for success. And that might sound kind of silly, but if you are really stressed out and can't find your shoes and you need to get out the door to get to work, it is going to add to your stress. You'll arrive to work stressed, and that's not a good way to start off. But if you always keep your shoes in the same place, you never have to worry about that. So don't underestimate the power of being organized, setting yourself up for success, having little routines. It all helps. Also, we want to have some positive metacognitive strategies. So metacognition is where you are able to think about your thoughts. So recognize the kind of thoughts that you are thinking, which is very meta, but is really important. So the brain doesn't fully develop this capacity until about the age of 25. So if you were younger, you may have to work a little bit harder to do this. But this is where you can stop and say, whoa, my thoughts for the past hour have been completely anxious, and I've been saying lots of negative things to myself, and I need to stop and, write in my journal, talk to someone, take a break, whatever the case may be. You want to make sure that we're having positive thoughts, rather than, oh my gosh, my patient died, I'm such a failure, you can say things like, I did everything I could, I worked with the team, we all gave it our best, and there is only so much we can do, we are only human. So think about how you're thinking and see how those patterns may be supporting you or holding you back. So finally, we have indicators. People told me that they could be at a resilience level, a survival level, or a burnout level. They may also be thriving, and they may also be experiencing post-traumatic stress disorder. Now, PTSD is a psychiatric diagnosis, and so that's beyond the scope of what I wanted to do with my research. But I'm sure many of the nurses would have described different points in their career where they were symptomatic for PTSD. I know I have been. I was having sleep disturbances because of constant nightmares. I would close my eyes and see a graphic situation I witnessed. I was being triggered by different things. It was all kinds of challenges. So thankfully, with professional support, I was able to overcome that. But it's important to recognize that there can be a wide range of experiences. And this can be day to day, and it can also be over years. So the important thing is not, where you are on my scale. It's how do you feel and how do you want to feel? And where are you in comparison to where you have been in the past, and where would you like to go? Also to say, if you are burnt out, this is not the end. Use this as a learning opportunity and try and step back and see what can I do differently, or what in my environment can change, and things like that. Don't see it as a personal failure, because this process is an ongoing cycle for the rest of our lives. So just returning to this model, I really encourage people to apply a public health approach to this. So a primary prevention approach would be trying to stop adversity. So make sure that we limit adversity as much as possible so people don't have to face it in the first place. The second would be to be aware of the impact. So when people, secondary level prevention would be when they are aware of the impact, can we do something about it? Can we try and mitigate so that it's not that severe? Then we get to further on, we have a tertiary level prevention where we're doing rehabilitation and say, okay, someone might be really burnt out or maybe really struggling. They might need some time away from work. They might need some professional support. Both of those things are valuable resources which are available to anyone. And how can we use that as a tool to bring them back into practice or help them move to an environment that they find more suitable? So I have a resilience handout on my website, which I will provide a link in the description. And so I encourage you to consider this presentation and look at the handout and just have a few minutes to reflect and think for yourself, how would I answer these questions, and how can I plan this so that when I am really struggling and I am having moments of burnout, I don't have to kind of start from scratch. I can take this off the fridge, look at it and say, you know what, I need to call my sister, or I'm going to call a colleague and just have a little chat after a shift. Whatever the case may be, take some time to think about it when you're away from work and you have time, and then hopefully that can be a tool that will help you when you are in an environment that may be more challenging. Here's some things that you can think about to discuss with colleagues or reflect on yourself. So I studied in an intensive care setting, but there's many settings that have adversity. What would it look like in your setting? What could success look like? And what stakeholders can be brought together so that you can work on issues to decrease adversity and improve staff well-being? So I gratefully acknowledge the support I received from my thesis committee and also from my funders. And these are the references for the diagrams and information that I use throughout the presentation. And please check out my website for more. Thank you for joining me for this presentation. I hope it's been useful to you. Please tweet, let me know what you think, or leave comments below. And I hope that you have a very resilient process in your day. Take care.